First, I'll welcome each and everyone. First, I like to thank Dr. Selvamuthu Kumaran for arranging this webinar continuously. I welcome Dr. Pari to be a moderator for this webinar. And I welcome Dr. Kodeeswarn and Dr. U.S. Srinivasan being a faculty for this wonderful webinar on how I do it session, starting with anatomy as well as with the surgical video. I welcome our office bearers, President-elect Dr. P.R. Rajkumar, Selvamuthu Kumaran, Magesh, and Satish Kumar, all the members of the dance for this webinar. Welcome you all, and our past office bearers, Dr. Murugan, Dr. Suresh Babu sir, and everyone. Please welcome, and we will start the program. Anything, Silva?
Yes, Dr. Pari, take
Over to Dr. Pari.
Hello. Yeah. Good evening to all. Thanks, Selva, for asking me to moderate the session. How I do it session, it's very useful, and we can learn new techniques. And before doing any surgery, anatomy is important. Here, first, Dr. Kodeeswarn is there to discuss about the C1, C2 anatomy, because C1, C2 regions, craniovertebral junction is involves a lot of pathology from congenital, infection, degeneration, so many pathology, neoplastic, so many pathologies are there. So everyone need to know the anatomy. And I request Dr. Kodeeswarn to start the anatomy. And there is no need to introduce Dr. Kodeeswarn. He graduated from Stanley Medical College, MCH, and he is doing a wonderful work. And he keep on doing a good work and continuously doing as a professor and HOD of Kilpauk Medical College. And recently also last week he conducted neurosurgery program for aspiring neurosurgical resident for the MBBS graduates. It's a great job. I welcome Dr. Kodeeswarn.
Thank you, sir. Thank you for introducing me. Pari is my elder brother in neurosurgery. Sir, I used to get all the guidance most of the time from Pari, sir. Thank you, sir. First of all, I would like to thank TAN's President, Dr. Suresh, sir, Dr. Selva, sir, and President-elect Dr. Rajkumar, sir, Dr. U. Srinivasan, sir, for giving me this opportunity. When I was an office bearer, I was not given an opportunity to talk in these CMEs. So this is the first time I'm talking in TAN CME, because when we were office bearer, we used to give chances to other people than office team. So thank you, sir, for giving me this chance to talk in front of all TAN's members. Coming to CV junction, it is the complex, unique anatomy in the entire human body. So I'm not going to talk about routine, that lines and all those things in CV junction. Today I'm going to talk about two different references. One is from Professor Atul Goyal's book about CV junction, and another one video which I was using during my post-graduation period from Dr. Auckland's anatomy series. So these two will be useful to understand the basic anatomy of CV junction and occipital region. The embryology of CV junction. So the occipital bone is not a skull bone. Basically, it is in development. It develops along with the vertebral column. So that is a unique point of that CV junction development. So the occipital bone, atlas and axis develops together. So that is why the CV junction is a unique system in our body. These are all the routine embryological development. So this development starts from 7th week of gestation, and the fusion completes at 18th to 25th year. So the various parts of CV junction develops from multiple sclerotomes, and also it will have multiple points, and also it will develops and from various part of the gestation, and also the fusion completes almost after 2 decades. The areas in anatomy, it's mainly bony structures of CV junction and ligaments and membranes of CV junction, vascular structures in CV junction, and also you should know the movements happening in CV junction. Regarding to bony structures, it is called C1 C2 complex, that is occipito atlantoaxial joint. And also ligaments, the main ligaments are atlanto-occipital membrane, cruciform ligament, alar ligaments, AL and PLL. The vascular structures, vertebral artery and venous plexus. The movements, totally it's a unique movement happening in occipito-cervical junction. That is forward and backward flexion, lateral flexion, and also rotation. Coming to the osseous anatomy, we have three important bony parts in this CV junction. One is occiput, second one is atlas, and also third is axis. So this is called C1 C2 complex. Coming to occiput is a one I already explained. It is develops along with vertebral column. So it has a oval to round structure called foramen magnum. The AP diameter is 35 mm and transverse diameter is 30 mm. It has two paired occipital condyles in the anterior half of the foramen magnum. The important anatomical part in this occipital condyle, it is always faces downwards, laterally, and convex. Why it is like this? Because it has to articulate with C1. So C1 superior articular facet. So that is why it was placed in that way. There is a canal just behind the occipital condyle. It's called hypoglossal canal. This area is called basion. This is called opisthion. Coming to C1, the important point in C1, it does not have any vertebral body. So it has anterior arch, posterior arch, and transverse process. In between these arches and transverse process, this area is called facet. That is superior articular facet. In the inferior surface, it is called inferior articular facet. These two facets, superior and inferior articular facets, together forms the lateral mass of C1. This is another important landmark in the CV junction, which is useful for most of the surgical approaches. So again, this facet, the superior articular facet, is facing towards the spinal cord because the occipital condyle is facing laterally. So they both together joint of C1 and occipital C1 joint. So this is the posterior view of C1. This is the posterior C1. This is inferior articular facet. This is superior articular facet. These two together forms the lateral mass. So this is the entry point of C1 screws. That is lateral mass screws. This is superior view of the atlas. This is the anterior arch, posterior arch, the lateral mass, transverse process, and vertebral artery foramen. Coming to C2, this is another unique bone in the C1 C2 complex, which has odontoid process. The odontoid process is actually C1 body. The odontoid process, which is attached to the C2 body, which articulates with the C1. This is the pedicle of C2. This is the superior articular facet of C2. This is lamina. This is bifid spine. This area is pars of C2. If you see the lateral aspect of C2, you can see the vertebral foramen, which is through which the vertebral artery passes through. This is the inferior view of the vertebral C2, which is having vertebral body. Now you can see the vertebral artery foramen, which has a different direction towards laterally from below. This is the anterior view of vertebral artery. The C2 vertebral foramen was removed in the anterior part. Now we can see the vertebral artery is going through the vertebral foramen of C2, and also it enters to the C1. So now in this view, you can see clearly the vertebral artery is arches and going laterally to the C1 vertebral foramen. And also, if you see here, the vertebral artery is going to the foramen magnum, making an arch of C1 lateral mass. So this is C1 posterior arch, this is C2 posterior arch. now you can see the ganglion of C2. This is another landmark in C1, C2 fixation. Whenever you trace this C2 ganglion, just behind the C2 ganglion, we will see the lateral mass of C1 and also superior articular facet of C2. So most of the time, we used to sacrifice this C2 ganglion to approach this lateral mass. Now I'm going to play the video, what I said early. Dr. Ackland from UK, he went to Kentucky and he was a plastic surgeon practicing in Auckland. He has published a series of anatomy. So this anatomy video I was using during my postgraduate time. It has a 8 minutes video. All postgraduate, please carefully listen this video. You will have a very good understanding of C1, C2 anatomy. So now this is a C1, C2 and occipital junction. Now you can see the movement of C1 and C2. Now the occipital C1 junction will have the forward flexion and backward flexion. That is mainly done at the level of atlanto-occipital joints, and also lateral flexion is done at atlanto-occipital joint. Now you can see the rotation, cervical rotation is happening at C1 and C2 junction. So now this is the routine typical vertebra of cervical region, which has vertebral body and lamina and the vertebral foramen. This is spine, bifid spine. This is the transverse process which has vertebral artery foramen. This is the superior articular facet of the cervical vertebra. This is the inferior articular facet. Together, it forms the lateral mass. This is the anatomical landmark, what we are using for lateral mass cruise. Now you can see it is connected with the intervertebral disc. This is the cervical vertebral body. This is the facet joint between upper and lower vertebra. Now coming to C1 and C2 anatomy, this is C1, which has the vertebral column. For the space, this is the anterior arch, this is the posterior arch. This is the two lateral masses, which has superior articular facet, which articulates with the occipital bone. This is the canal for spinal cord. This is for odontoid process. So the vertebral foramen at C1, which has both spinal cord and odontoid process. Now you can see the vertebral artery foramen here, which is placed almost in the lateralmost part of C1. So that this entire area is called lateral mass. This is important landmark for most of the CV junction surgeries. Now coming to C2, this is the odontoid process. Already explained. This is the lateral facet of superior articular facet of C2. This is the vertebral foramen at C2. This is the inferior articular facet. So the superior articular facet and inferior articular facet is not closely related in C2. Now the both C1 and C2 together forms the rotational movement of neck, and also it has the major movement is happening at C1 and C2 junction. So the most of the movements happening in between occipital C1 and C2 joints. The remaining vertebral joints does not have much mobility, which is maximum is having only 10 to 20 degrees of movement. This is the part where the alar ligaments are getting attached. This is the articular point of odontoid, both anterior and posterior. Posteriorly, it is articulating with transverse ligament. Anteriorly, it is articulating with the anterior arch of C1. Now coming to the entire complex of occiputo C1 C2 junction, this is the posterior vertebral line. Once it was removed, now we can clearly see this is C2, this is the foramen magnum, this is occipital bone, this is C1. This is C2 vertebral body, this is odontoid process. This is the occipito C1 junction. This is C1 and C2 junction. Now, if you remove the posterior most part of the lamina and also spine of the entire occipito-cervical region, now you can see the ligamental structures of C1 and C2. Can you see here? This is the occipito C1 membrane, which is continuously forming as posterior longitudinal ligament. It is attached to the skull base. So the entire holding system was starting from skull base, and also the entire holding system is transferred through the entire spinal column. This is anterior arch of atlas. This is odontoid. This is the atlanto-occipital membrane. It is attached to the skull base. Now it is continuously as PLL, posterior longitudinal ligament of cervical region. Now coming to the ligamental structures. Now you can see the atlanto-occipital membrane, which was removed now. This is called cruciform ligaments. So it's one of the strongest structure in the CV junction, which has two parts. One is transverse ligament of atlas, which is attached in between to the articular process in front of odontoid process. So it prevents the posterior displacement of odontoid. It has two upper bands also, superior and inferior band. Together it forms cruciform ligament. It's one of the strongest ligament structure in CV junction. Now coming to the alar ligament, which is attached to the tip of odontoid process. And also to the occipital condyle. It prevents the excessive rotation of C2. So it limits the rotation of C2. Now coming to the entire sagittal view, this is atlanto-occipital membrane. This is transverse ligament of atlas. This is called yellow ligament. This is ligamentum flavum, which is giving the support of posterior part of the spinal canal. This is posterior arch of C1. This is occipito C1 membrane. And also it's called atlanto-axial ligament. So these are the ligamental structures which are supporting the CV junction. Now, this is the reference taken from Professor Atul Goyal's book. The maximum strength of the ligamental structure is cruciate ligament. Next to cruciate is alar ligament. So this is the book which was written by Professor Atul Goyal. So who are all passionate in this area of CV junction, you should go and read this book. So now my respects to Professor Atul Goyal and Dr. Ackland. Thank you all for your attention.
Very nice demonstration of anatomy, Cody.
Thank you, sir.
It's a very clear-cut presentation, and actually it's very useful. That Ireland's anatomical video. It's every graduate resident should go through it. It's very much useful. So we will have the question at the end of the session. Now I request Dr. U.S. Srinivasan sir. U.S. Srinivasan sir completed his MCH from Madurai Medical College, and he is having more than 25 years of experience. I know him from the days of his PhD days, and he is like my elder brother and senior colleague. I always take his opinion most of the time, and he had more than 120 publications, and he had some first in the world, 5, 6 first reported specific things, and he wrote the books also, and he is a very great teacher and keen on teaching also. I request E.S. Srinivasan sir to present his recent about C2 Dome Laminoplasty, which he is doing now. You sir.
Dr. Parry, thank you very much for your introduction. I hope, am I clear? Am I audible?
Yes, sir.
Yes, sir. Yes, sir.
Right. Thank you very much for your introduction. And at the outset, I like to thank the organizers of TANS and Selvam for giving me an opportunity. My job has been made easy by Dr. Kodeeswarn beautifully explaining it and showing the video of it. I didn't expect a video to be shown. Beautiful video of the CV junction. And in that, I really appreciate Kodeeswarn to coming forward, despite the audio problems coming forward. That is the life of neurosurgeon. We plan, suddenly something goes wrong, which doesn't go according to our expectations. Then we need to change our methodology. That's what Dr. Kodeeswarn did. Hats off to him. And this is the real life situation in neurological procedures, as most of them would have encountered. I'll be presenting on C2 Domelike Laminoplasty, how I do it video session. And commonly, as you are aware, for C2 OPLL, as in this case, yes, this was the case. I did it earlier in my career. We used to do a C2 laminectomy, C3 extensive laminectomies from C2 to C7. This is the post-op MRI and post-op CT scan. My process used to say C2 should not be removed because it's, as Dr. Kodeeswarn showed, it is one of the most important structures, but I used to remove it. Later, 15 years before, I accidentally came across a book written by, a chapter written by David Bradford in Masters in Spinal Surgery, which changed my idea of dealing with the C2 lesions, which are anteriorly placed. That is the thing. Today's presentation is based upon 12 cases of C2 Dome Laminoplasty out of more than 750 cervical cases I have operated. Am I clear? Am I audible?
Yes, sir. Yes, sir.
Oh, yes, sir.
Right. Yes. This patient, 68 years, presented with progressive quadriparesis for more than a year, which worsened in the last 3 months. She had difficulty in tying her hair and difficulty mixing food. And she felt her right leg was weak than the left. And she had difficulty in walking also. She needed support even to stand. She is medical history only, she is a diabetic. Examination showed quadriparesis with the level above C3, and neck movements were severely restricted, but her hairline was normal. I used to go by single breath count. Single breath count was greater than 50. Other systems were normal. This is the clinical presentation. In suspecting an abnormality in CV junction, I ordered for an X-ray. You can see the X-ray. X-ray shows the dens is separate from the C2 body. And these margins are clear, as you can see in this. And there is a scoliosis here in the AP. There was no AAD. There was no basilar invagination. I ordered for an MRI scan. And this is the MRI scan picture, which showed severe compression at the C1, C2 level anteriorly with the hyperintense signal within the spinal cord. The radiologist report was fracture base of odontoid process noted with the superior migration of odontoid process. Then I asked the patient whether she had sustained any injury. She declared, she said throughout last 15-20 years, she had not even fallen down. So fracture of the base of odontoid process, I thought it's not unlikely, but there is a retroflexion of C2 causing compression of the cervical spinal cord. There is significant indentation anterior to at C1, C2 level. And spinal canal was severely narrowed with diameter of only 4.9 millimeters. Please note, diameter was only 4.9 millimeters. And in this axial section, you can see the spinal cord is transversely elongated. CT scan of CV junction was done, and the radiologist report was multiple loose bodies in the atlantodental intron, severe osteopathic complexes along the lateral masses, retroflex C2, and narrowing and kinking of the cervicomedullary junction at C1, C2, as you can see in this. I had a diagnosis dilemma itself in this case. What is it? And what for management? What is the diagnosis dilemma was, yes, there is a retroflex angulation of C2 causing severe cords. There is, in this, there is no doubt regarding that. There is significant indentation anterior to spinal cord at C1, C2 level. Yes, agreed. The spinal canal diameter is 4.9 millimeter, which indicates a spinal stenosis. But the radiologist has reported fracture base of odontoid process, but there was a smooth base. So what it is? Then I thought it may be an ospodontoidum causing compression. Then going through the literature, I found out ospodontoidum over years, it has chronic instability leading to spinal stenosis. So in this case, what to do? Whether just a C2 Dome Laminoplasty or a stabilization. I decided, considering the possibility of ospodontoidum causing chronic instability and spinal stenosis, because spinal canal diameter is 4.9 millimeter, I decided patient requires stabilization. But to go anteriorly, I had published a paper on C1, C2 dense fracture, a single lateral mass with single screw fixation. But all these cases, when I analyzed, it was within 2 to 3 months after fracture. So putting a screw here to here is almost more than a year. I did not have confidence. I thought it will not work because multiple loose bodies are there and we will not be able to bring it into normal alignment. So decided to go posteriorly. This is the management, surgical management dilemma I had. This is the consent for the youngsters. For the past 25 years, I get a detailed consent like this, explaining everything to the patient. And depends if the patient comes from Bengal, I get it in Bengali language, or they know Hindi, I translate it and do it. This is that, and I have not landed in any legal problems. I request you to follow this. This is my kind request to the youngsters who are starting their career. Then, in this case, after making a diagnosis of C1, C2 compression, surgical worker is most important. Anesthetic evaluation. He is the most important person in my life because all depends, success or failure depends upon the anesthetist. So I used to send my patient 2 days before to my anesthetist, Dr. Arivamani, who used to do. He saw the patient and said there will not be any problem during intubation. But still, I also discussed with him. I told him this is the case where I'll be using intraoperative monitoring. So he has to adjust his anesthetic drugs. He said no problem regarding that. But I advise him, let us keep bronchoscopic intubation set ready in the OT in case if he is not able to. We did not encounter, I did not encounter problems in the previous 10 cases also, but still we kept the bronchoscopic intubation set in the OT. This is the first case where I used intraoperative monitoring. Previous 10 cases, I didn't use intraoperative monitoring. And he changed the anesthetist as anesthesia drugs. So asking me whether intraoperative monitoring is absolutely essential. In the majority of cases, I didn't use it. This, I decided to use it because I had it. Pulmonary function tests, textbooks say normally in all CV junctions do all pulmonary function tests, but not only in this CV junction cases, transoral surgery, I never did a pulmonary function test. I don't do it, but I go by single breath count. If the single breath count is more than 15, then I am confident patient will not go into ventilator. Second, I start the patient on spirometer 1 week before itself. And 2 days before, I ask the patient to get admitted and look to what extent they are able to blow the balls out of the 3 balls. If they are able to blow 2 balls, I'm extremely happy that the patient will not go into the ventilator post-operatively. This is what I do it, and I'm successful in these cases. Coming to the C2 Domelike Laminoplasty, I decided in this because of the compression. anteriorly. This was described by Matsukatsu. This is known as Masuzaki method. As you can see, this is the compression, and the C2 arch is retained, but the anterior aspect of the C2 spinous process is removed, expanding the spinal canal. Normally, the spinal canal diameter in this level is 15 to 20 millimeters. It varies, but in our case, it was only 4.9 millimeters. So only to expand the spinal canal, I decided to do a C2 Dome Laminoplasty so that it will not create unwanted instability. Positioning in this prone position, neutral position, and I always use skull fixators. And please check that, it's most important. Secure the endotracheal tube properly, reconfirm it repeatedly. Reason is, what I suggest is don't use horseshoe because there is a risk of visual loss is present. This occurred in one of my cases, partial visual loss in the 5th or 6th cases. Why? Because while using the drill system, there was compression from the posterior and anterior. Even though I took all care to it, luckily I escaped. So please don't use horseshoe. Use always 3-point skull fixators, whether Sujita or Mayfield. Then don't overflex there. We have got a tendency as neurosurgeons to get optimum position during laminectomy, lumbar, cervical, or whatever it is. So, but in this case, there is anterior compression. Please don't overflex the neck. Whatever position you get, please proceed with it because there is a risk of paralysis. Is there already anteriorly it's compressed and it's fixed. Anterior column is fixed. So if you try to overflex it, you will not get it. But under anesthesia, you can do it, leading to further cord compression paralysis. Another thing is endotracheal tube. This is most important because you are doing it in the prone position. Anesthetist will fix and said okay, but again recheck it. Make it very clear to the anesthetist that it should be properly fixed. Reason is because of the weight, it can get pulled down, and after the betadine scrub, this betadine solution will go and loosen the plasters. This occurred not in this case, in my case, but in a case of a transoral surgery where I did it. Fantastic transoral surgery I did. Then put the patient in the prone position, and patient had a tracheostomy at that time because anesthetist insisted on it about 15 years before. Then we did it, and the endotracheal tube slipped. It was new anesthetist for me. After on that day, luckily I escaped. From that day, I insist and recheck that plasters are properly fixed and endotracheal tube is secured properly. Sterility is most important. Strict aseptics, thorough betadine scrub of operative site is most important. Reason is your wonderful surgery can, if the patient develops infection, either meningitis, CSF leak, accident, CSF leak, or the gets infected, implant needs to be removed. This is how I scrub. Yes, everyone has got their own method, but I do give a betadine scrub starting from the center, going to the periphery. This is mainly meant for juniors, and the company says 2 minutes you scrub, 1 minute you wait, 2 minutes you scrub, 1 minute. But if I do it, my anesthetist will throw me out of the theater. So I scrub for 10 minutes from the center and go to the periphery. I don't even give my assistant, allow my assistant to scrub. I scrub all cases. The last more than 1,200 consecutive cases, there is no infection. This is most important. Scrubbing is most important. Initially, I was using lignocaine with normal saline, but my anesthetist infiltration solution, he asked me to switch over to ropivacaine, lignocaine and adrenaline 6 drops, and I am using it. I hope I am audible and clear. Hello?
Yes, sir. Yes, sir. Audible, sir.
Fine.
Audible, sir.
Right. Now coming to skin incision, when you are draping it, the 3M betadine drape, cherry drape you use, the incision can get submerged and you may put it, be careful about it. And I use a 20 blade knife for incising the skin and 10 blade knife for incising the subcutaneous tissue. I don't use monopolar till I go deeper because so accidentally monopolar can touch the skin edges and can interfere with wound healing. Another important point is in these skin creases, you have to scrub properly because this is a source of infection. And again, you will have to make all efforts to extend the incision up to that level. Skin creases is the most important thing. Once I go to a certain extent, then I use monopolar. And once I see the fascia, I start dissecting it on either side. That white fascia, if you see, dissecting it on either side. The reason is, if in case accidentally CSF leak occurs, It gives a beautiful closure so that we don't get into a CSF coming out of the thing. Another thing is it's easy to apply retractors. You need not retract, ask the anesthetist to give more of muscle relaxant. So I dissect it on either side. Then coming to the muscle separation, right? This commonly like similar to what we do in lumbar. I use first most important here, palpate the spine. C2 spine can be palpated. Without that, confirm it, identify the midline, and then use monopolar cutting to separate the muscles from its spine attachments. Use cups for superior cell separation of muscle. Important thing for youngsters is what you should not do is don't deviate from midline. Don't go into the muscles. If you cut the muscles, bleeding is going to be there. So don't deviate from midline. Your monopolar should kiss the spinous process and you should go keep it at minimum thing, because initially they would have kept it at very high, adjust it and adjust the monopolar thing, eat current and keep it at minimum. That will be sufficient to separate the muscles. Yes, I have got the luxury. If you don't have CM, nothing to worry about it. But I have got the luxury of using the CM. There is no need for it because C1, C2, as Dr. Kodeeswarn showed, has got a unique anatomy which can be palpated. C2 spinous process can be palpated, occiput can be palpated and marked. But since I got a luxury, I use CM. The most important is C2 C3 junction is most important to identify it. This is most important. I'll tell you why later. Identification of C3 spinous process is most important in C2 Dome Laminoplasty. Now, once this I do the subperiostral separation of muscles, which everyone is familiar with it. Use the monopolar and separate, and finally use the gauze piece to remove the pericardium from that and separate it out. Expose the completely the thing and expose the foramen magnum. Most important is expose the foramen magnum lip. Till this stage, even C2 is exposed, but C1 I am not exposed, as you can see. I have not even made any inclination to palpate it to find out C1. Here, be careful while using monopolar close to foramen magnum. Keep it at minimum. Now coming to the exposure, again I go down, expose the C2 spinous process and identify the C2 C3 space. That is most important, and expose the lamina of C2 on both sides. Apply my retractors. This I have modified it, as you can see, this Ramani retractor, but I put 2 plates to retract, not 1. And another thing what you see is this is a beautiful instrument known as GLP, which retracts the suboccipital muscle. So only these 2 instruments are there in the field. Then comes the dissection of the fascia over the C1 posterior arch. Identify the C1 posterior arch, posterior tubercle of C1. In this case, it was completely rotated to one side. And regarding that, initially I use a 15 blade knife once identified to remove the fascia over it. And then very rarely I use monopolar and then use the gauze piece to separate it out. When you are using monopolar, keep it at minimum. You can see the next thing. The fascia has been separated out. The C1 posterior arch is completely exposed, as you can see in this. This is C2, this is C1, this is the occiput. You have to expose. I expose for 10 to 15 millimeters on either side. The posterior tubercle was rotated to one side. That indicates the vertebral artery, everything will be rotated. So you have to be very careful when you are coming for fixation. So C1 arch is exposed, C2 is exposed, foramen magnum is exposed, C3 is also exposed in this. Before proceeding further, you should clearly delineate the anatomical structures. Then identify the C2, C3 place. I truncate the C3 because to drill it, I truncate, remove partially C3 spinous process, and then use that. I use a 2 millimeter diamond barbette. You can see. Identify the most posterior aspect of the C2 spinous process using a dissector. Then start the drilling from the center. Start the drill. Don't keep the drill over that and then do it. It will slip. Start the drill from the center and go on all sides. You can see the drilling, and this should press upon it Don't keep it vertically. You may injure the spinal cord. As you go, we should press upon it and it should be parallel or nearly horizontal to the spinal, parallel to the spinal cord. So you can use this to keep, you can see the thing. This drill bit handle is pressing the thing. Sometimes you may have to extend the incision to get this angulation. Don't hesitate to extend the incision halfway through the surgery. No egos in this case. You can see the thing. I always use a diamond drill bit and keep on with it. Intermittently take it. Simultaneously, my assistant will be irrigating and take it and feel it. You can see the thing. The posterior aspect of the C2 spinous process here is retained, and I am drilling inside. As I go further down inside, it's a blind drilling, so it will be more. I keep it more parallel to the spinal cord. Here. So most important is to identify the C2, C3 spaces, truncate the C3 partially spinous process to get this angulation, and keep drilling. As you are keeping drilling, please keep pressing here posteriorly over the thing to obtain the angulation. Now, after this is over, drill like a saucer, don't drill like a cup. Up to the center of the spinal canal, you can go. Please don't use cutting bar. Now, literature advises to use beyond correct and remove the cranial end of the base of the C2 spinous process, which is very difficult to do it. It becomes difficult to use because C1, C2 junction, this is the area where there is severe compression. There is a risk of paralysis. So I have modified it. I use drilling even from that. For that, C2 spinous process drilling at the base from the superior aspect. You can see I don't use Kodeeswarn punch. Even now, if you are saying till now, I have not used any Kodeeswarn punch. I use the drill again from the center. Identify the center. That is a part of the thing. Soft tissue I kept so that muscles can be easily sutured later. So drill, again press it here. Keep pressing it as you go deeper. That is towards the spinal side. This is occipital side. This is the spine side. Keep pressing it. Again, this is a blind thing, but you can easily safely do it because posterior aspect, just posterior to spinal cord, that bone is retained. Don't remove C1 posterior arch till the drilling is over. Please, most important, don't remove C1 posterior arch till the drilling is over. That protects your spinal cord. Then, most important here is you 5 to 6 exterior, 5 to 6 millimeter posterior aspect of the C2 spinous process has to be retained, which you can do it and use a probe to identify the completion of the thing. Next, I'll show you. Then here at this stage, only I bring my Kodeeswarn punch and start removing it. The thinned out bone, easily you can do it. Using your 2 millimeter, I use 2 millimeter upcutting Kodeeswarn punch. It is safe and everyone is used to it. Safe, you know. The important thing is to note is be careful not to injure the dura because due to long-standing compression, it could have been thinned out and there is a risk of injury. So under vision, see where you are keeping the Kodeeswarn punch, the base of it, and take it out. Be gentle, don't pull it. You should cut it. You can see the thing. And the direction should be towards posteriorly when you are removing the thinned out bone. Similarly, I do it in the anterior aspect also. And once it's removed, to confirm the completion of it, I use a nerve node probe. You can see the thing. It is easily moving from the posterior, this is fine, from to that anterior line. It has come. It is easily moving. C2 arch for 5 to 6 millimeters is also retained. This confirms the completion of the C2 Dome Laminoplasty. Then I complete, as everyone is aware of it, easily the C1. Now at this junction only C1 posterior arch I remove it. Posterior laminectomy I did because C1, C2 compression was there, severe compression. Using 2 mm again, 2 mm upcutting. Posterior laminectomy of C1, posterior arch, I completed it. Now in this case, as I told you, I had a dilemma whether to go it for fixation or not, just a C2. But since it was os orientoid, I'm going through the literature, it's better to, there is instability. I did not take the flexion extension views because I was not confident of subjecting the patient with a neurological deficient and 4.9. So I went for a lateral mass fixation. As Professor Kodeeswarn explained beautifully, the entry point, C1, C2, entry point for screws below C3 as per Magnum is 2 mm medial and 2 mm anterior to the articular process. 2 mm medial and 2 mm anterior. It should be directed anterolaterally, and you can put the probe that should be parallel to it. But entry point for C2 lateral mass, because of the vertebral artery comes, it should be towards midline. Strictly speaking, it would have been better if I had done a C2 thing. But since due to financial constraints, I did not do an angiogram. I was not sure where the vertebral artery was because and intraoperatively it was rotated. So I didn't go for a C2 lateral mass fixation. This video I'll show you. After identifying the articular process, then 2 mm medial and superiorly I started drilling. I always use a diamond burr bit. And direction was anterolaterally at C3 level, and intermittently use this probe to find out. But one thing I felt is you can go boldly deeper and you will feel the giveaway sensation once you reach the anterior end. Do not worry about it, provided your direction is clear. And you have to angulate your drill bit. More thing. As you go, keep drilling it. You can see I'm angulating it, pressing the thing. Anterolaterally, it should be the thing. That is the most important aspect in this drilling. And after that, after the drilling, you can see the giveaway. And once you get the giveaway, then the company says they give a 2.75 millimeter tap. Please don't use it. That will break the thing. I never use a tap to do it. After that, directly I put the screws. Even though it's 2 millimeter, they give a 3.25 millimeter screws or 3.5 millimeters. You put I tried it. That will break the thing. Lateral mass. So please don't use a tap. You can directly put the screws. This is what I learned. This is the direction of anterolaterally. Drilling at C3 level should be anterolaterally, as I told you. For the juniors, don't get flabbergasted or overwhelmed by the set of instrumentation. Actually, you require only this. I used a 12 millimeter length, 3 millimeter with self-drilling polyaxial titanium screws was inserted. And occipital plate was put. And this, as you can see, occipital plate. I am not happy with the design. I told the companies. Initially, Synthesis company earlier had a beautiful design of occipital cervical fixation. And their C2 screws were blue color, which was directed 25-degree medially. But unfortunately, now this company has been taken over and this is not available in the market. This design becomes very difficult. I'll show you why. The company gave this to insert the occiput screws. I tried, but couldn't go inside. Occipital bone was thick. I couldn't do it. The company said, you do it. Company person was standing outside and said, you can do it, sir, you can do it. But I couldn't do it. It was blunt screws. Then what I did is use my 2 millimeter diamond burr, made a small, entered the entry point and then use it. You can hear my assistant talking. He says, again. You can hear. Then I use this 10 millimeter length, 4 millimeter width on either side of the midline. Other slots are useless because this should be parallel exactly in line with it. It cannot be just like that. You can put a rectangle, triangular or rhomboid shape thing. Then a template was made using that thing and the rod was contoured to suit this thing. And the fixation was done. You can see the fixation. Rigid fixation was obtained, and bone chips obtained from C1 laminectomy and C3 truncation was laid over the facet joints on either side. This is the operation notes. I do give a detailed operation notes. I type it. Post-op care. Immediate surgery, 1 day in ICU kit. First post-op day shifted from ICU, check X-ray cervical spine. Lateral taken to verify the position of implants. If proper, there is no problem. Dad catheter, always catheterize the patient. Clamped and released once in 4 hours from post-operative day. Removed on second day. Am I audible? Clear?
Yes, sir.
Yes.
Audible,
Right
sir.
on second day. Venous Doppler study I do on the second post-operative day. There is clinical or radiological evidence of DVT. Then I started Klexen. For few cases also I started depends upon the thing. Opinion differs in the third post-operative day with Philadelphia collar. Gradually make the patient to sit up 30, 45, 60, 90 degrees, which is given for 4 weeks. No collar during lying position. But textbooks say that master techniques in spinal surgery, Bradford says for 15 days you keep the patient bedridden, but I don't do it. From third post-operative day, I mobilize. Third 3 days I give parenteral antibiotics, even though both are cephalosporins. So fourth time I give because it is the only thing that covers pseudomonas also. So I give both this for 3 days because of the fear of infection since implant has been put. Fourth post-operative day, patient is made to mobilize and made to walk with Philadelphia under physiotherapist supervision. Initially, I talk to the physiotherapist and tell them what they want. That is most important. You talk to your physiotherapist, or else they will do whatever it is, and you are responsible for it. They are made to go to the restroom. Post-operative day 5th, made to walk in the hospital corridor with the help of relatives because they are the people who are going to take care once the patient goes home. So you have to train them. Elastomer bandage is 5 days and then remove. 6th post-operative day morning, I take a check X-ray cervical spine to verify the position of the implants. If proper, patient is discharged. On the 6th day, I don't keep till suture removal with the advice of Philadelphia collar. I give a detailed discharge summary for the youngsters. This I found in Japan about 20 years before. They do a beautiful thing. So pre-operative thing, then intraoperative pictures and post-op. So you have got a permanent record for presentation and you document everything that will help you out. Post-op suture removal is done between 11th and 4th depending upon the patient's medical condition. Cervical collar is given for 4 weeks daily except while lying down or during sleep. I ask them to come after 1 month for review. Check X-ray. 5th and 6th week to remove the cervical collar every 2 hours because suddenly if you remove, then they will feel something is missing. 7th and 12th week during travel only I give. If they are allowed to work from home if they are in IT sector from 3rd week. Allowed to travel by 2-wheeler after 2 months. Review at 3 months, 6 months, 1 year during every time. Every review I take an X-ray cervical spine. This is the post-op thing. You can see the C2 spinous process here intact. Occiput to C3. Yes, there is a question whether C4 should be included or not because this is not involved. I didn't do it. And since C2 Dome Laminoplasty was done, the question of gross instability is less in this case. So I didn't do anything. I didn't extend my stabilization to C4. This is the patient, 1 month. And I asked them to use a walker in the house because I have seen being in an orthopedic hospital after a few days, especially elderly patients, they skid and fell down and then they develop a fracture femur or anything. So I don't want them to land up with the orthopedician. So I ask them to use a walker for 1 month, especially in those patients whose power is grade 2. This is 1 month later. She had grade 2 power. Right leg was weak. Now you can see her walking with walker. Very good improvement with it. Even though Philadelphia collar was advised, they don't use it. They use their own cervical collar. Yes, you have to agree with it. This is another case. That case, another case of C2 Dome Laminoplasty. In a few minutes, I'll be completing. C1 laminectomy was done. This is the C2. You can see the C2 posterior arch. Retained. Dome Laminoplasty done. You can see the thing beautifully. 5 to 6, and the probe is used to confirm the completion of C2 Dome Laminoplasty. You can see that is going. This is another case. It was done. This is the another case of C2. You can see the extensive OPLL here from C2 Dome. C2 Dome Laminoplasty was done. C2 spinous process is retained in this, and lateral mass fixation. C3, C4, C5. Laminectomy, decompression laminectomy was done, and lateral mass fixation was done. Patient is doing well 10 years down the lane. These are the cases whom I operated. So to summarize it, for anteriorly placed lesions at C2 vertebral level, like OPLL or Osseous compressing the cervical spinal cord at that level, causing neurological deficit, C2 Domelike Laminoplasty is safe and effective procedure with excellent outcome, even in the long term for 10 years. For OPLL only, C2 Dome Laminoplasty is sufficient. There is no need for stabilization. But if you suspect an unstable area, like Osseous with instability, then occipital to C2, C3 lateral mass fixation can be performed. I am able to perform it because of the equipments given by management, and the most important is my neurosurgical OT team, who are always cooperative. And this was recorded using, all this procedure was recorded using mobile phone camera. My sincere thanks to them. These are the books that I published, as Dr. Parry has said. And I like to thank Dr. Selvakummaran, Secretary TANS, and the President-elect, Office Bearers of Secretary of TANS for giving me an opportunity to talk, and Dr. Parry and Dr. Kodeeswarn. Thank you very much for each one of you for your attention. And you can start the question. I am prepared to answer your doubts. Thank you very much.
First, Naveen, you unmute everyone. Unmute everyone. And any questions? Anyone can ask. There was no question in the chat box. Anyone want to ask directly, you can ask. Otherwise, I can route. It's a very nice presentation, sir. Very nice presentation. Nice demonstration from anesthesia, pre-op workup, and clear clinical evaluation, and preoperative workup, and positioning, and every step, each and every step you have explained in detail, sir. Very nice presentation. And positioning, you told already you faced the problem of blindness. It's a nightmare for surgeon. You are not using horseshoe. That I had burned my finger recently. Maybe 1.5 years ago, one patient developed blindness. Then after that, I started using Mayfield retractor for all my case. My case never recovered. That it happened after very so many cases, but it's a nightmare for surgeon. What is your experience about that, sir? Blindness.
See, regarding my case, I told you a few years before I was using this thing, and same C2 Dome Laminoplasty I did, and I had a partial. I was lucky. I used horseshoe in that case because I did not have a my 3-point fixator went broke on the day of surgery when I fixed, because it was very old. So I couldn't. I had to use horseshoe. I had a partial thing, but I've seen my orthopedic colleagues in the previous hospital where I was operating use the horseshoe, or then operate on even the, not only the CV junction but cervical laminectomy. They used to do it.
Even yes, sir. Even lumbar laminectomy, it has been reported, yes, but the exact reason was not known. But it's a nightmare for surgeon. You cannot explain to the attenders.
Yes,
and yes, sir. Another thing is we will do a good decompression for OPLL, and sometimes we fix lateral mass or laminoplasty. Patient also improves, but after 6 months or so, if you are doing MRI, it may be a shock. Sometimes they may deteriorate. If you're doing, there is a kink-like thing at the C2. So this may be a solution. This dome laminoplasty may be a solution for that. Sometimes I used to do undercut, but instead of that, the decompression was not adequate. That was I felt. But this may be an alternate option, I think. What is your opinion, sir? If you, after laminectomy and lateral mass fixation, if you are seeing C2 level compression, what will you do? Kinking like thing. Sometimes there is a CSF column, you can see beautifully below that C3 to C6, but there is a compression like thing near C2. That is very common. I faced a few times.
See, in this case, as I told you, I modified the thing and I started drilling from, even though textbook don't give, I started drilling from the superior aspect, right? That prevented this thing, right? This was my modification, and then used upcutting. But in case if it occurs, for example, after surgery, patient recovers and then post-operatively few months later, if the spinal canal diameter extrapolating my cervical spine, if the spinal canal diameter is more than 7 millimeters, clinically you observe. If that clinically there is no deterioration, there is no need to worry about it. Observe, monitor the patient. If clinically there is deterioration later, years later, 1 to 1.5 years later, again patient develops, do the MRI. If there is a compression, go ahead and do the decompression at that level.
Sir,
Okay.
I have not encountered that problem.
Dr. Yes, Srinivasan.
Dr. Suresh.
Very nice presentation, sir. Both Dr. Kodeeswarn and Dr. Yes, Srinivasan. Just one question for sir. You are talking about the dome laminoplasty. Will you remove the ligamentum flavum or not after the dome laminoplasty?
Yes. In few cases, I used to easily you can lift it up. As you can see, you can lift it up and remove the ligamentum flavum. It comes out on its own. You can lift it up. And sometimes when you are using upcutting itself, you remove part of the ligamentum flavum.
No, whether we can do or not is not the question. Whether we have to do or not.
No, it is not. No, it is not. Last few cases, I don't do it. Last 4 cases, what I did is, after doing the dome laminoplasty, using a dissector, I lifted it up more posteriorly. And what we need is a space for the spinal cord, expansion of the spinal canal. So I don't completely, as textbooks say, I don't remove the ligamentum flavum. Last few cases, I used the dissector between the ligamentum flavum and the dura and lifted the ligamentum flavum both from the top as well as bottom, which is more than sufficient.
Okay.
Hello.
சுரேஷ் பாபு சார் இருக்காரா? சுரேஷ் பாபு சார் கேளுங்க. சுரேஷ் பாபு சார் இருக்காரு நினைக்கிறேன்.
Sir.
நீங்க மிச்ச பாடெல்லாம் பாத்துருவாங்க. நெக்ஸ்ட் பாடம் பாத்துருவாங்க. இல்ல எழுதிருக்கீங்க.
Sir, Suresh Babu, sir. Sir, are you there?
Yeah. Can you hear me? Yeah.
Sir. Yes, sir. Yes, sir. Hearing you, sir.
I listened to both talks, very well prepared and well explained talks by Kodeeswarn and Srinivasan. The Kodeeswarn's talk was excellent, no doubt about that. Only thing is, I just want to emphasize that there is no weight transmission in from the head, from the skull down. Odontoid does not carry weight. I think it's a very important concept to know that the weight transmission goes through the lateral mass. Lateral mass of the C1 to the body, 80%, 20% goes to the facet joint posteriorly. So that I thought we should also give importance to that. It was a very good presentation, Kodeeswarn.
Thank you, sir.
I just wanted to, I really did not understand one thing. See, the compression was from the front, right?
Yes.
And in case if you do a transoral microsurgical or transnasal endoscopic decompression, then we can get the good decompression because the compression was more in the front and it was slightly at a higher level than the C2 spinous dome.
It was at the C1, C2 level, sir. Earlier, if it is a basilar invasion, I have done a transoral surgeries. I do agree with you. But later, I found out that, say, transoral surgeries also sometimes, when you do it after that, this was not a basilar invasion. As you had seen, it is osseous that was below the level of the foramen magnum.
Yeah.
It was below the level of foramen magnum and compression at C1, C2. So only I removed the C1 posterior arch and as well as C2 Dome Laminoplasty. Both I did it. Initially, I planned for a foramen magnum decompression also, but closely analyzing the thing, at foramen magnum level, there was no compression.
So usually, now the current standard procedure is Goyle's procedure. When C1, C2 sublase, you can very well put a Goyle's procedure, put a bit distract a bit, then you will get a good decompression at the same time stabilization. You can preserve the movement at the Atlanta occipital at C2, C3 level.
Yes, sir, I agree, but I'm not familiar. To be honest, I am not familiar with that procedure. And another thing is there was a C1 rotation, posterior, as you can see. You have seen C1 arch. When I intraoperatively that on one side, it had gone so deeply, right? So I was a little bit reluctant to go ahead and do that procedure in that. So only I didn't do it. I do agree with it.
So, I mean, I know safety is a very important concept, and we have done whatever is best for that patient. There's no doubt about that. So, I was just because, I mean, if the patient had come to me, probably I would have done Goyle's procedure. That's what I thought. That's what I wanted to share you.
No, I agree with you, sir.
Cases where you have done, but there is no instability, and you did only dome laminoplasty. It's an excellent procedure. I have not done that, but I think it can be easily done. Now, see, slowly we are proceeding toward endoscopic spine surgery, including a cervical spine. So with endoscope, this can be done much easier.
Yes, it is, I agree, but I have not tried about it because what is only in three cases I had where there was C2 OPLL and C4 C5 disc anterior compression, C6 C7 anterior compression disc. So what I did in that case is only C2, that video I showed you in the last, only C2 dome laminoplasty, no stabilization. Then did a anteriorly I went and did a C3 C4 or C4 5 discectomy. And with endoscopic, yes, we can do it. But it takes endoscopic, as you are aware of it, it takes time to master the techniques. For lumbar spine, I used to do it. The standard endoscope, I had it. And I used to do for lumbar discectomy and other things. Even transthoracic, I have done it. But cervical, I am not confident about doing the thing.
Yeah. We have just started doing that. So, but the standard all is different. I think we should go for a fully endoscopic technique only. That is, I think Kodeeswarn also has the set.
Yes, sir. Yes, sir. Now the concept is totally changing, sir. According to me, the C1, C2, most of the problems will settle down with Goyle's procedure. The joint distraction is the key. So what Dr. Goyle says, the majority of the problem is at C1 and C2 level. So if you do the joint distraction and fixation, most of the compressions will get, even nowadays he's publishing, I almost published so many papers that syringe also getting completely resolved. Once you do these kind of C1, C2 fixation, mostly I'm the very strict follower of Goyle. So I don't have much experience in this procedure, sir. And also full endoscopy. Now, according to endoscopy also, nowadays the descent is totally gone. Almost nobody is doing descent nowadays. Now the full endoscopic, wet endoscopy has come. Now it is becoming very popular. Now most of the young neuroscience are taking up, and we all also should slowly transform to full endoscopic spine surgeries.
See, I mean, as most of us are only neurosurgeons, I want to warn all neurosurgeons, if you don't start doing endoscopic spine will be taken over by anesthesiologists and orthopedic surgeons. More orthopedists are now just getting an orthopedic degree, and they are doing this in Maharashtra and other places. It is so rampant. So I think all neurosurgeons should start doing endoscopic spine, and of course, it should be the way in soon. Anyway, Dr. Srinivasan, I really enjoyed your video and the concept of removing only the compressive element of the anterior portion of the spine while preserving the posterior portion is an excellent concept. Good. Thank you for letting us know this new surgery which I have been doing. I have not done this. Thanks.
Thanks, sir, this is indicated mainly in the this case was osmodentoidum, but C2 OPLL. Yes, the previous all my cases. Unfortunately, I couldn't get the MRI pre-op post-op MRI. I was searching for it, right? Because once in 2 years I used to do it. So C2 OPLL, definitely this is indicated where fixation already it is there. There is severe compression, spinal canal diameter is narrowed. And it's very difficult to go ahead and remove the C2 OPLL anteriorly. So this procedure is useful in C2 OPLL.
Thank you, sir. Each and every common cases, as if we do, that's good. Today is very good. Anatomy by Dr. Kodeeswarn followed by surgery. It's a nice thing. Like that, I think we can proceed with each and every common case, then go for a complex cases also.
Thank you, Dr. Suresh. Thank you, everyone. Thank you. I think we'll wind up this meeting. Thank you, Dr. Naveen.
Thank you, sir.
Mr. Naveen. Thank you,
Thank you, sir.
Thank you so much.
Thank you, Srinivasan, sir. Thank you, sir.
Thank you very much, sir.
Thank you. Thank you all.
Sir, shall I end the session, sir?
Yes,
Yes,
anybody.
yes.
Thank you.
Thank you. Thank you.